you. We want to see you. Don't worry. Nothing against you.
We'll take that personally. Okay. As Prophet Diva had gone through in tremendous detail, there are multiple documents on a global level that stipulate the principles of human rights. And as Sheela dealt with some of the things that she mentioned, these principles have been extended to people who are incarcerated. So this is a document from the United Nations Human Rights Commission on the basic principles of human rights that are extended to people who are deprived of liberty, also known as people who are incarcerated. Thank you. And one of the key statements that I wanted to point out in this document, that all prisoners should be treated with respect due their inherent dignity and value as human beings. And I think everybody in this room, by nature of the work that we do, understands that concept and how that should be applied to people who are prisoners as well. This document also is going to move to the end of this statement that all prisoners retain their human rights and fundamental freedoms, despite their incarcerated status. Now, moving on to another United Nations document originated in 1957, updated in 1977, that there shall be no discrimination on any grounds, as it relates to the treatment of prisoners. So these are holistic concepts that have been implemented on a global scale. And then further, in 2015, the United Nations, the General Assembly, adopted this resolution named the Mandela Rules, after Nelson Mandela, one of the most celebrated people of the last century, who was formerly incarcerated and who developed tuberculosis during his incarceration. So the statement of treatment of prisoners were updated in 2015, 2016 to reflect medical services in particular. And just to, there's like, I think 122 of these rules in this document, just to excerpt a couple of them. The provision of health care for prisoners is a state responsibility. Prisoners should enjoy the same standards of health care that are available in the community. Number 2, healthcare services should be organized in close relationship to the general public health administration in a way that ensures continuity of treatment and care. And they specifically call out HIV and tuberculosis, as well as other infectious diseases, as well as drug dependence, knowing that these are highly prevalent conditions in this population. And even in Rule 25, every prison should have in place a healthcare service that's comprehensive and attends to the physical and mental health of prisoners. And then number 2 at the bottom, the healthcare service shall consist of an interdisciplinary team with sufficient qualified personnel, acting in full clinical independence, acting in the best interests of prisoners, independent of their prison administration. So these are some very powerful statements. And I think one thing that all of us will appreciate is that we are very far from that ideal. The gap between evidence-based interventions and what actually is delivered to people who are in incarcerated settings is tremendously wide. The gap between what's delivered to the general population compared to what's given to prisoners is tremendously wide. And this is just one example. Somebody named Altice published this a couple of years ago. This is just an example of what's happening in Eastern Europe and the former Soviet Union republics. Looking at metrics of HIV prevalence, TB incidence, prevalence of opioid-dependent individuals, and availability of opiate agonist therapies in community settings versus in prisons. And look at any of these across the board, and what's happening in prisons is much more dire than what's happening in communities. Okay. I wanted to have everyone think about this as a cascade. I'm borrowing from the HIV and TB and applying it here. It's not just the incarceration period that we need to think about. It's what happens before and after as well. It's all part of this. So the pre-incarceration period, the incarceration period directly, but also the post-release. What are the factors that contribute to risk? That all happens in a community setting, but pre-incarceration. There's policies or structural factors and individual level issues that contribute to this increased risk that leads to potentially poor outcomes amongst these people who are experience ongoing fear of harassment and discrimination, these structural factors related to criminalization of substance use and criminalization of sexuality, disruption of existing resources at a community level, for example, safe injection practices, prolonged pretrial detention, inadequate legal representation, lack of health services while even in pretrial detention. And then certainly anybody who experiences any of the intersectionality here. So for example, someone who's a member of a ethnic or racial minority and happens to also be a drug user, for example, suffers synergistically. During incarceration, policies that facilitate overcrowding, ongoing condoned, seemingly, discrimination and violence against people who are incarcerated, and just the overall inadequate health infrastructure. Lack of testing, care, and prevention for HIV, Hep C, tuberculosis, OUD, that's highly prevalent conditions in this population. And post-release, and planning for that post-release period, that transition. Poor planning for discharge, lack of linkage to care for HIV, TB, OUD, hepatitis, all of the things that were being attended to during incarceration. And certainly lack of connections to housing and social supports upon release. And we all know that without those, people who are released experience worse outcomes. There's lots of potential strategies. There's a tremendous amount of work to be done. Certainly on a policy level, working to end criminalization of key populations, working to reform laws that to dismantle sexuality and substance use as crimes, reducing the duration of pretrial detention, and on a local level, with regard to specific health services, developing screening for high-frequency conditions, integrating prison-based health services, facilitating planning for post-release care, improving community-based drug treatment programs. All of these things are examples of things that we can be doing. There's lots of attention, especially in the last year or two, about how equity plays a role, a central role in implementation science. Lots of calls to action, and how can we use implementation science to address these injustices. This is just one paper that's come out in the last year or so, calling on us to think about equity as a central tenet of the work that we do. Building equity into the metrics that we use, into the models that we use to frame our work, building capacity for equity in our partnerships, and also in our dissemination efforts. Prof. Diva already briefly went over the Harapan 2 study that we're doing now. I'm very fortunate to be part of this team. Just to emphasize a couple of key points about what this project is doing. As Prof. Diva mentioned, we're implementing a procedure to screen all prison entrants for tuberculosis, connect people who are diagnosed with active TB to treatment in a timely fashion, introduce new evidence-based interventions to improve diagnosis, improve and implement TB preventive therapy for those who rule out for active tuberculosis, getting those people treated for latent tuberculosis, provision of antiretroviral therapy and OUD treatment services, and integrating all of those services, which is critical. Another thing I think that's been very important is incorporating stakeholder input. So working with the Ministry of Health, Ministry of Justice, getting input from prisoners and from the staff. This kind of multi-level assessment that informs the intervention and informs what we're going to be doing next. And then certainly everything that we're doing is accounting for the context in which the prisoners reside on a daily basis, what their experiences are. Literally on a daily basis, how do they go from point A to point B? How can we incorporate the services into their daily lives with the restrictions in the prison setting? Perfect. My email, looking forward to the discussion. Thank you, everyone.